Welcome to this presentation on the topic of communication and escalation within the maternity setting. Good communication is a vital element of our care and when done effectively can help contribute to improved patient safety. Escalating concerns is another communication related skill and can be difficult in a busy and loud environment with the person you're escalating to sometimes not even seeming to listen to what you have to say. So we're going to take a look at the roots of escalation today as well. So these are the learning objectives. By the end of this session, it's hoped you'll have a greater awareness of the principles of effective communication and some tools that are used within UK practice to assist you with conveying your care plans in a simple yet detailed manner. And then secondly, it's hoped you'll also come away with an awareness of the necessity of escalating your concerns and how that contributes to your safer practice of midwifery. It's always a helpful reminder to all healthcare professionals working in the NHS to come back to the 6 C's underpinning compassionate care. When we get these right, we're on the right path to provide great service. And number 4 here today for us to revisit is a big one, communication. This infographic is from the NHS England website. I will cite all resources I've used at the end of this presentation with some links for you to do further reading. As it's concisely written here then, communication is central to successful caring relationships and effective team working. And listening is as important as what we say. It's also essential for the no decision without me, meaning we should involve people in every aspect of their care and decision making. And finally, it is the key to a good workplace, with the benefits not just for the people in our care but staff as well. It promotes safety when we encourage good working relationships, when you know who can help you on a shift, and when the person receiving care understands the role of everyone involved. Effective communication is also a required professional standard upheld by the NMC's code and backed by the Royal College of Midwives, who state that midwives must have the ability to communicate effectively with all members of the maternity team, so other professionals, women receiving care and their family members. They should ensure that all information is relevant to the care pathway, it's accessible, aids decision making and assists communication. The Code of Practice by the NMC has a whole section about communicating clearly, and to do so, we need to not speak in jargon or medical terms that people won't understand, but also think about providing assistance in terms of communication support to those who need it. We also require a range of methods of communication, verbal, non-verbal, and we need to consider cultural sensitivities as well. It's good to check people's understanding too, sometimes clarifying that the information we are giving has been received and received correctly improves care quality. So in summary, what does good communication look like? Well, it's all of these things listed here: building trust in relationships, active listening, empathy, problem solving, goal setting, and using motivational language. Now, these are tools which are important for use with absolutely everybody you encounter in your working environment, with the clients and their families, your colleagues, multi-professionals, including students, support staff, cleaners, and the likes. Let's come back to different types of communication that we need to draw on to be effective. We've got verbal, and if you're anything like me, it's easy to just reel off a whole load of words and information. However, we need to be careful in how we express our verbal communication. It's important that we're providing accurate information, not guessing answers to questions, etc., sticking to what we know and otherwise seeking help for tougher questions. When we're the ones asking questions, we should think about trying to phrase them openly, giving space for a person to answer fully in their own way, rather than giving room only for a yes or no type answer, which doesn't actually give you much information. Again, clarifying understanding, repeating and even rephrasing the same information in a slightly different way can be helpful to explain complex information. And we need to be mindful that not everybody, even other professionals on the shift, will understand our medical jargon, like abbreviations or shortened names for things. So when we're communicating verbally, we want to gain trust, we want to build rapport with others, develop our working relationships, and so being mindful of the tone and pace of our words and voice can be important too. We want to demonstrate empathy, respect, and our care in doing so. Now we've also got non-verbal communication, which I want to explain fully on the next slide. Then we've also got other types such as written or electronic information. Some people, as I've mentioned, may need communication aids such as the use of an interpreter or for sign language interpreter. Some may need to use braille or other hearing aids. Let's come back to non-verbal communication now then. Our non-verbal communication is thought to make up about 80% of our communication, so we have to be extremely mindful of this. Just want to touch on a few forms of non-verbal communication. We've got facial expressions. These tend to be quite universal, and we can read each other's emotion often through the facial expression. Gestures. These are deliberate movements and signals that give meaning without words. Now, some are really common, like waving, pointing, and giving a thumbs up. Others are very arbitrary and relate much more to culture. They are still powerful and influential, and so I would say if you're unsure of the meaning, it is always best to clarify to avoid misunderstandings and to care for other people well. Next, we've got paralinguistics such as loudness or tone of voice. This vocal communication is separate from actual language. The effect of tone of voice can change the whole meaning of a sentence. When said in a strong tone of voice, for example, listeners might interpret a statement as approval or enthusiasm. The same words, however, said in a hesitant tone can convey disapproval and a lack of interest. Body language. This provides a great deal of information. However, it can often be really subtle and it's much less defined than people have previously believed. Regardless, it's encouraged that you maintain an open posture, generally communicating that you are listening and being non-confrontational, while, for example, crossing your arms may demonstrate the opposite. On a similar vein, we've got proxemics and personal space. The proximity that you stand away from another individual and the amount of space that you perceive as belonging to you. Cultural expectations, again, will vary greatly here, as well as there may be situational factors or personality characteristics that affect how comfortable you are with space. Generally in the UK, it can be considered rude to stand too close to someone, or indeed too far away, so we're a bit complicated, us Brits, with communication preferences. Again, if in doubt, it's always best to ask. Eye gaze. Eye contact can indicate a range of emotions, with looking, staring, and blinking being important cues. People also often utilise eye gaze cues to gauge a person's honesty. Normal, steady eye contact is often taken as a sign that a person is telling the truth and is trustworthy. Shifty eyes and an inability to maintain eye contact, on the other hand, is frequently seen as an indicator that someone is lying or being deceptive. Appearance. Our choice of hairstyle, makeup, and other appearance factors can also be considered a form of communication. I will note, while this is less desirable, people generally react, make judgments and interpretations based on our appearance. First impressions are important. However, if you're adhering to your uniform policy, etc., and are still made to feel judged for your appearance in a negative way, just know that this is not okay and it can cross over into discriminatory behaviours and attitudes. Last on this list, we've got artefacts, and by that I mean objects and images. You may also find people wish to look at what you're wearing and take an interest in your uniform, which tells them at a mere glance who you are, your job title. Your ID badge gives your name and your job title. You'll notice the hierarchical structure within your workplace by the uniforms that people are wearing, etc. So we need to be mindful of all of these non-verbal forms of communication, which make up so much of how we're interpreting and communicating. A dictionary definition of self-awareness is as follows: having conscious knowledge of your own character and feelings. It takes practice to become an effective communicator, and the way that we communicate with each other and with those we're looking after here in the UK is likely to be very different from what you're used to, depending on where you've practiced before. You will likely notice subtle societal differences that require background knowledge or explanation to understand the context and full meaning in some situations or conversations. And for that reason, I would say that it is so important that if you are unsure that you understand what someone else is trying to say to you, that you always seek clarification and ask plainly if necessary for them to repeat it in a slightly different way or explain something to you. We should all be communicating from a position of understanding of who the audience is, what they are wanting or needing from the conversation, what information needs to be conveyed, and also how another person's own thoughts, character, and feelings play a part in the communication. The idea that we have the opportunity to be kind and considerate to every single person at any stage of their care by seeking all we can do to support their understanding of the care that they are receiving. This is Dr. Kate This is Dr. Kate Granger, who was a doctor who fell terminally ill with cancer, and she realised whilst an inpatient in hospital that many of those who looked after her never took the time to introduce themselves properly. She started a campaign called Hello, My Name Is, publicising the principle that an introduction is a basic element of compassionate care and a core principle of communication. So listen up, midwives. Your name and your reason for talking to someone should be the start of every conversation. Let's briefly touch on the importance of a detailed handover as a means of good communication to reduce risk and increase safety. As you know, a handover is a transfer of information, responsibility, and accountability from one person to another. They usually take place when there is a shift change or cover for a break, as well as within your working day, for example, when the person in your care is moved to another ward area, or the doctors on shift come to review your woman in labour and ask you for a handover. Handovers promote patient safety and continuity of care. We can use the Swiss cheese model. If you've ever seen a Swiss cheese, you'll know it has lots of holes dotted through it. People make mistakes. Everyone knows that happens. However, a good handover, be it verbal or written, will mean that there are fewer holes, such as in this Swiss cheese model, to fall through, and the team that you're handing over to will thank you for giving them a complete handover. So with our regular ward reviews and changes of one-to-one care in labour at shift change, etc., we need all the relevant information ready and as complete as possible to give clearly and concisely to whoever is receiving handover. There are some tools that aid the handover of patient information, for example, SBAR. You've probably heard of SBAR. This tool stands for Situation, Background, Assessment and Recommendations. It's a useful tool that helps structure your information to communicate clearly and convey the key events and concerns. It's recommended and widely used in lots of maternity units and can be used verbally or in written communication. Let's look at this written example of an SBAR. So you might start with the situation, so the patient's details, why they're in an inpatient, for example. The background is all their significant information, so the patient's identifiers, her parity, her gestation, her blood group, all of this stuff. For example, Jane Doe, hospital number, date of birth, her parity, she's 39 weeks plus 3 days, she's B positive blood group, she's had her latest HB done on the 17th of July. She had a completely low-risk pregnancy, but her partner was born with a heart abnormality, so she's been under the paediatric team through her pregnancy. She's admitted today with signs of labour. Assessment. So what is your assessment? What has brought the care to this place at this time? For example, Jane is in active labour with a history of her cervix being checked at 5 centimetres dilated at 4:30 in the afternoon. Recommendation. Now you're going to make your recommendations for continued care and highlight any extra details to remember for the care moving forwards. For example, we're going to continue with routine labour care. We're going to offer to re-examine the cervix at 8:30, which is 4 hours from the initial examination. The neonate will need a paediatrician at delivery due to the history of dad, and they will need to facilitate the newborn infant physical examination due to the history. You may give a verbal handover in a very similar style to the example I've just given as a written down one, going over all the fine details. This is an example more to the point as an emergency is taking place and the information needs to be faster and clear. So first we're going to think help and pull the emergency cord, call or ask someone to call emergency 2222 and state what the emergency is clearly. As every single person arrives, each time the emergency needs to be clearly stated. So the situation for this emergency is postpartum hemorrhage, and we're going to state that really clearly for anyone arriving into the situation. You can give a little bit of a background. We've had a spontaneous vaginal delivery at 18 minutes past 9. We had a second-degree tear which had already been sutured. The estimated blood loss, however, has risen to 600 mils and active bleeding has increased to quite a heavy flow. Assessment. What's already been done? We've already given syntocinon. We're about to give syntamimetrin, but we may need some further support. So the recommendation, maybe you're going to make a suggestion. Would you like to take over so that you can continue caring just for the mother and baby? So that's an example of SBAR in use within an emergency, and it's just a really great way of structuring the information that you have to say. As I've already stated, but I honestly can't state enough, and we know from international midwives who have gone before you, the cultural norms are likely to look very different in asking for help, advice, and for others to come and do something for you, do a task for you. So if you take anything from this presentation at all, I hope it's that you're able to observe this quite quickly in practice and understand what I mean. You shouldn't feel afraid of others judging you or like you're wasting someone's time when you are escalating a concern or merely just asking a question. And in clinical practice, sometimes you have to keep escalating if the immediate people are all busy or someone's brushed off your concern and you still remain worried. On shift, you might initially flag your concern with the midwife in charge, who may recommend that you ask for an obstetric review. There are usually different grades of doctors working in as a team in maternity, and generally you escalate from the lower grading upwards. But if your concern is not addressed by one, you definitely need to keep raising it with another. This comes a little into not working outside your own scope of practice as well, which is mentioned in the NMC code. And by this we mean you should never be asked to or work outside of your normal limitations of your qualified role. Now, your scope as an internationally educated midwife will likely change a little as you settle in the UK, whilst you're awaiting your registration, etc. However, a qualified midwife is not responsible for creating high-risk care plans. And so when you have a concern, for example, in labour with an abnormal finding, you just need to document your efforts to escalate your concerns and keep asking for help. The Royal College of Midwives and Obstetricians put together this helpful tool, which might also help you to frame some of those conversations and in order to maintain clear communication through your concern. It's designed to be used before a full SBAR of information and uses these 3 simple phrases at the bottom of the left-hand infographic. 1, I'm asking for advice. 2, I am informing you. 3, I need you to do. Let's quickly look at the examples given. So instead of saying Nadia in room 7 is fully dilated and wants to use the pool, we could say instead, I am asking for your advice around using the birth pool for Nadia in room 7 as she has a borderline blood pressure. An example of informing somebody of something. So instead of saying, just to let you know, Alia in room 4 is fine now, we should say instead, I am informing you that Alia in room 4 had a kiwi at 0530 and a pph of 1000 mils, but is now stable. And instead of saying, Maggie is fully and pushing with a dodgy CTG, instead we could ask someone to do something. I need you to brackets do. I need you to come straight away to review the CTG in room 2, which is deteriorating. These 3 simple phrases, advice, inform, do, really help structure your escalation and what you're asking of somebody. Additionally, these principles of effective team working are also worth looking at briefly. Now, it's an easy thing for you to implement in asking yourself at the start of every shift, do you know everyone who's working today? Do you know exactly who you're going to escalate your concerns to? Have you thanked a colleague? Have you celebrated your successes together? Have you checked to see that your colleagues are okay? Everyone adopting these widely makes clinical escalation a lot easier for everyone and gives each team member a voice so that they can raise concerns without fear. Kindness and compassion should be visible in an effective team, and maternity care has to work like this as a team. Now, when you have a particularly difficult shift, maybe you've seen something that you disagree with or feel may have led to an unsafe situation, it is of utmost importance that you act on this recognition. Every team member has the responsibility to create safe service provision. It can be a really hard thing to do, though, and can feel like you're taking a shot at your colleagues or creating a scene over something relatively small, and ultimately it didn't cause any harm. In turn, it can make you feel like you're being a bit over the top or a bit of a snitch. This shouldn't be the case. You should be able to discuss what you see in practice freely, and our workplaces should remain open learning environments. So, whether it's something affecting the care of the service users or you've noticed bullying or belittling in your work area, it needs to be heard so that action can be taken. So, we're talking about general escalation now. The NMC would recommend a staged process of escalation if you feel something isn't being addressed. So initially they recommend starting to speak to someone like your line manager, or maybe it's your practice development team, if you feel comfortable and able to do so with these people. It might also be an opportunity for engagement with a professional midwifery advocate, who are designated midwives to help you in addressing any concerns you might have. Generally then, you might escalate further, maybe even with the initial person's help, to discuss it with someone who may be able to address the concern, such as a ward area manager or matron. And still, if internally you are not satisfied that the issue has been addressed adequately, you can then go on and contact a regulatory body such as the Care and Quality Commissioners, who will investigate the matter. If you're worried about someone's conduct, you can also contact the NMC. And always remember, if you're not satisfied with someone's response and you are still concerned, you need to keep escalating. My top tip is find someone quickly when you arrive in the UK within your unit that you can talk to comfortably and freely. Do this as fast as you can. They can then be your go-to person when you have any worries. Your practice development team or professional midwifery advocate will probably be a really good fit for this. Okay, so these are our references for today. Thank you so much for listening, and I hope you found this really helpful on communication and escalation. Do let us know if you have any comments. We'd love to hear your feedback on these resources.
Please follow this QR code, and there's a link just below the video to a feedback form for us. Thank you so much. See you next time.